Hello, my name is Mengyu Wu. In this presentation, I will share our study, Less Uncertainty, Less Questions, What Educators Should Know Before Deploying AI Teaching Assistants. Our research question was straightforward. Under what conditions do senior medical students engage with a curated generative artificial intelligence teaching assistant? Rather than assuming that learners will use an AI teaching assistant simply because it is available, we wanted to understand when they actually perceive a need for it. I will begin with the background and the aim. This project came out of a continuing effort to improve a flipped classroom on fetal circulation and congenital heart disease for senior medical students. The topic is complex and multidisciplinary. Learners must integrate embryology, anatomy, physiology, pathology, and clinical reasoning. Over several years, we progressively refined both the learning materials and the classroom activities in response to student feedback. This slide summarizes 3 cycles of curriculum development. In the first cycle, in 2020, we built an online flipped classroom in response to the COVID-19 pandemic. Students completed pre-class e-learning and then took part in oral question and answer during class. That aim was achieved, but students reported anxiety during the oral questioning. In the second cycle, in 2022, we introduced Kahoot as a gamified formative assessment. Participation rose and anxiety fell. That aim was also achieved, yet the cognitive load of the content itself remained high. The third cycle, in 2025, is what I report today. Our aim was to build a retrieval-augmented generative AI teaching assistant to deepen students' understanding of the course materials during self-directed learning. One point matters for everything that follows. These materials were not built in a single pass. They were refined over 3 cycles, and their quality is the premise for today's findings. The next section summarizes our educational intervention. This is the mobile interface of the e-learning platform. It was designed so that students could reach the materials easily on a phone, a tablet, or a computer before the classroom session. The intention was to give learners control over the pace, the sequence, and the repetition of their own learning. The platform held 2 lecture videos, 2 corresponding ebooks, a collection of National Medical Board examination questions, a knowledge map, and a self-assessment with feedback. The first set of materials covered fetal circulation and the general principles of congenital heart disease. The second covered cardiac development and common congenital cardiac anomalies. Students could move freely between these resources and choose whatever they judged most relevant to their own needs. A direct link to the curated AI teaching assistant was embedded in the platform. This is the user interface of the generative AI teaching assistant, which is a modified ChatGPT. It was developed specifically for this course. Using retrieval-augmented generation, its answers are confined to the course material I wrote myself and several authorized textbooks or clinical guidelines. So students receive content that is relative, accurate, and course relevant, rather than the uncurated ChatGPT. It was offered as an optional support during self-directed learning. We assumed that students would interact with the AI teaching assistant frequently because they would have many questions to ask in order to deepen their understanding of such a complex topic. The curriculum was implemented as a distributed and spaced learning pathway across the semester. First, 138 students took part in pre-class e-learning. Second, the same 138 students attended the in-class Kahoot session, which provided formative assessment and immediate feedback with explanation of the correct answers. Third, a subgroup of 14 students subsequently took part in bedside teaching in the pediatric intensive care unit, where they met real patients and examined ventricular septal defects on a 3-dimensional printed heart model. The bedside number is much smaller, because the lecture is compulsory for the whole year. Whereas small group clerkships are allocated by the clinical rotation schedule, across different teachers and different topics. The 14 students were assigned to my group by that schedule. 1 week beforehand, I briefed the students on the patient's diagnosis and hospital course, and suggested that they prepare for the case, using the AI teaching assistant. The e-learning platform and the AI teaching assistant remained available to students throughout the semester. I will now present the main results. We examined 3 quantitative findings: engagement with the pre-class materials, performance and self-ratings during the Kahoot session, and self-reported use of the AI teaching assistant. We then drew on written reflections from the bedside subgroup to explore how the learning context shaped students' perceived need for AI support. First, the learning analytics show that students did engage with the pre-class materials. Lecture Video 1 received 122 views, Lecture Video 2 54 views. But mean viewing time was under 20% of the full video length in both cases. What matters is that viewing was concentrated in particular sections. The transition at birth segment of the first video reached 51% average viewing. Cardiac tube formation and common anomalies in the second reached around 40%. The ebooks were also well used. Ebook 2, on cardiac development, had 121 unique visitors and 238 openings. And 123 students completed the pre-class quiz, with a mean score of 74.65 out of 100. So low AI use did not reflect a lack of pre-class learning. Students were engaging with the structured materials selectively, rather than linearly. Their attention followed their uncertainty. We then compared the bedside subgroup with the remaining students in the cohort. Performance on the Kahoot assessment was similar. The median number of correct answers was 7 out of 10 in every group. Self-rated mastery before and after class was broadly similar, as were their ratings of the course materials. One row stands out: the rating of the generative AI teaching assistant. The bedside subgroup gave a median of 9, against 6 in the cohort overall, and among the other students. Note the timing here. This questionnaire was completed in the classroom, before bedside teaching took place. So this is not an effect of the clinical experience. These students already rated the assistant more highly at that point. Hold on to that difference, we will return to it. Next, self-reported use of the AI teaching assistant before class. Of the 138 students, 45.7% never used it, and 13.8% used it only once. Around 24% used it occasionally, between 2 and 5 times, and only 16.7% used it more than 5 times. Read conventionally, this is a failed system. But look at the 2 columns on the right. Perceived helpfulness rose steadily with frequency of use, from a median of 5 among those who never used it, to 9 among frequent users. Meanwhile, Kahoot performance was the same across all 4 groups, 7 items correct. So use of AI assistant was unrelated to performance, but closely tied to perceived value. Low adoption did not mean dissatisfaction. It suggests instead that many students never perceived a need for additional help. The qualitative findings help us interpret that pattern. 14 written reflections were analyzed thematically, and 2 contrasting themes emerged. The first theme: when the learning materials are well organized, uncertainty about the coming lecture fades. One student described the content of the e-learning platform as clearly presented, with text and figures together, so that whenever he got stuck he could pause the video, replay the key part, and think it through again. Several students felt that reading the materials would be enough to pass the assessment. In this highly structured environment, the materials already met their needs. The question never had a chance to form. The second theme when students needed to face a real patient, uncertainty returned. Here they said they needed someone to organize what they needed to know and explain it. One student wrote that the AI assistant gave him a basic grasp of both diseases beforehand, so he could follow the teacher's explanation at the bedside. The same students, the same tool. What changed was what they were preparing for. So, do learners always engage with a generative AI teaching assistant during self-directed learning? Not necessarily. They engaged when the scenario carried substantial, unresolved uncertainty. Where well-organized materials already provided a clear pathway, the perceived need for AI support was reduced. Where students entered a less structured, more authentic clinical setting, uncertainty rose, and the same assistant became valuable. Therefore, low adoption should therefore not be read automatically as the AI system failure. In some settings, it simply reflects the absence of need. That absence may itself be a sign that the instructional design is working. There are 3 take-home messages for you. First, students embrace generative AI teaching assistants when they face genuine uncertainty during self-directed learning. Second, well-organized learning materials mitigate that uncertainty and therefore reduce the need to seek help from the AI assistant. Third, educators should deploy generative AI teaching assistants in complex, less structured clinical scenarios, rather than in didactic settings with well-structured learning materials. Remember, less uncertainty, less questions. Thank you for listening.